So at this time, I want to break down for us kind of the whole protocol and what we do specifically that is different than what anybody has seen. So there's a tinnitus assessment that happens in the beginning, and that is the first thing that anybody who have tinnitus, who whether you've been to a hearing test or you have not, will describe to you what really is the difference here. So tinnitus assessment 1 is what we call, is the first part of the tinnitus assessment. And what exactly do we do there?
Yeah, so now this can be done in office, or we can do this, I've done this over the phone or remotely, but we'd like to go through a case history and medical history, a little bit more thorough than normal. That way we can figure out exactly what's been going on, what's your main concern, see if there are any correlations between other medical history in your life.
Yeah, because we're looking for the other outlying causes, right?
Yeah.
So aside from just kind of testing your hearing, is okay, tell me all the case history related to hearing loss. It's much more comprehensive than that, right?
Yeah.
Okay.
Then we typically, so if you're in the office, we'll complete something called a otoscopy. So we'll take a look at the outer ear.
Yeah, so that's like looking out the ear.
Blue light. We'll also run something called tympanometry, which we're testing the middle ear. It's almost like if you think of it like a pressure test, we want to make sure that the eardrum is working properly, rule out any possible potential sinus issues or middle ear problems. And then that's when we'll get into the audiological evaluation, where you're sitting in a booth. And now the interesting part about this test is that it's a lot more in depth compared to like the typical hearing test where we're testing from 250 hertz to 8,000 hertz. With this one, what we're doing is we're testing 250 hertz all the way up to 20,000 hertz. And the reason being is that we want to make sure we're not missing out on any possible hearing loss or hearing deficiencies that we may have missed out only by testing up to 8.
Yeah. And this is very important because I've tested a lot of patients where they come in and show me an audiogram that they've done either at our clinic or even somewhere else, right? And see, I don't have hearing loss. So see, how can you guys keep telling me that this is hearing loss related or whatever? But when we test them at 10,000 hertz, they're in the moderate range already.
Yeah.
And by 12,000 hertz, they just drop. And subsequently, the next test that we do is really interesting. We do a tinnitus matching. And this tinnitus pitch matching, we're able to actually match and quantify exactly where you perceive your tinnitus, down to the hertz, down to 1 hertz, okay, differentials. So then we're able to isolate, okay, so now look at this. So you have a hearing loss at 12,000 hertz, the most severe level, and you also match your tinnitus to 12,000 hertz. So just because you had a normal hearing test done between 250 hertz to 8,000 hertz, it doesn't mean that, you have this test done. So this is a very important part of our test.
Yeah.
Along with that, we also do loudness scale matching. So we match the level or loudness of your tinnitus. And this is significant as well because part of the therapy is understanding the problem. And a lot of people, they come in and tell, my tinnitus is on a scale of 1 to 10 is sitting at a 9. And then I'm able to show them that after we do this test, actually they match their tinnitus only 6 decibels above their kind of minimum or threshold of hearing. Like the softest sound that you can hear at that frequency, you add 6 decibels. It's not very much.
No.
But that is where you match your tinnitus, if you were to actually match it. And so that understanding that your tinnitus is actually not as loud as it is, but what you have done psychologically is made it much worse, right?
Yeah, made it much,
that is a
much louder.
huge reflection, and understanding that is half the battle, right? And then the last thing we do is we do a test for maskability. So we're looking at what sound was most effective at helping you to be able to draw your attention to another sound. And without that ability, we oftentimes are able to, teach you to habituate to the other sound, right? So we need that sound to be, so we look at that maskability test as well, okay?
And that assessment is about an hour and a half. And then part 2, this will help us determine actually really important underlying causes that could potentially change the whole outcome of TRT. So what does that entail?
Yeah, so for that one, we do several different scales of inventory questionnaires. So we do that THI that we talked about before. Again, that's the tinnitus handicap inventory. We also do a tinnitus evaluation and And there's a whole bunch of questions about, how you're subjectively affected by it, your activities that you're affected. So we chart all this out at the beginning, and we're able to come back to it at certain points in our program, and we reevaluate, and we're able to show you, you may not remember, 6 months later where you were.
Yeah.
And now where you're, because everything happens progressively and gradually, right? So when we look back and say, hey, remember you were a THI of 88, which is considered catastrophic category, but now after 6 months of treatment, in fact, we have a couple of patients that I can recall right off the top of my head that actually went from 88 to like 16 or
Drastic
something,
change,
right?
yeah.
It's a huge drastic change. It's not a 20 dB or 30 dB or 30 point drop. It's like a 60 point drop. And when you talk to this patient afterwards, they would go from saying that I hear my tinnitus all the time and it's bothersome and I have all these emotional attachments to it and I hate it, to like I don't really hear it, I sleep fine with it and I don't even have concentration issues or focus issues. And that's a huge improvement. So our goal is always to try to get as far as we can and not just look for the clinical 20 point significance.
Right.
In this part also, we also talk about like subjective findings. We explain, we do this kind of therapy here where we specifically apply to you, right? And because not a lot of the conditions we talked about in general terms so far applies to everybody, right? So we customize or we specify the conditions and the treatment and discuss the whole treatment plan.
Right.
But one of the key things that I want to talk about that we also do in the second part is something called a DST evaluation. And this is something that I think is for sure, I think one of the big differentiator between many of the other therapies out there, okay?
Yeah, absolutely.
So Dr. Yashubov has invented, if you will, the terminology called misophonia. So if you ever look it up, lots of people who have misophonia, they know it. Like it's amazing how they have found this term themselves, or the doctors have told them. But did you know that misophonia the word came from Dr. Yashubov and another professor or one of his colleagues, and they came up with this word misophonia. It's not I guess it must be in Wikipedia now, right? Misophonia, but he created the word. Yeah. He created the word,
Yeah.
Did you ever create a word?
No.
That's in Wikipedia?
I mean, I've created words, but I don't think they're in the dictionary.
Yeah, exactly. So by definition, let's talk about DST, because DST has a huge significance.
Yes.
And we oftentimes overlook this. And in many cases, if we can identify this portion, it is the key to solving the problem. Okay? So what is DST? Why is it important, Lacey?
It's important. So if we think about a term called acoustic trauma, this is really the underlying cause of what could potentially cause this DST, decreased sound tolerance. And so if you think about decreased sound tolerance, think of it like an umbrella. That's the main term, and then underneath there can be something called misophonia, phonophobia, which we'll get into, and something also called Tensor Tympani syndrome. So first off,
as well as hyperacusis, right?
Hyperacusis,
yeah. So let's talk about each one of these and kind of the definition, because I really want you guys to understand. And it's never asked, because when I ask patients about these conditions, they're like, wow, like you guys, I've never had anybody ask me this. And I didn't even think this is anything related to my tinnitus.
Exactly, yeah.
But it is, okay? So let's start with the first one.
So hyperacusis, so this is an abnormally strong reaction happening in our auditory pathways. And this typically happens when we hear really loud sound. And the important part about this one is the loudness of the sound. Then if we look at misophonia, which is what you're talking about, what's that one?
So misophonia is instead of being all loud sounds, so instead of being that you are sensitive or annoyed about all loud sounds, so at a certain loudness level, you can't do. Misophonia is very specific. So it's a very specific sound, or if you will, a type of sound or a pattern of sound. So examples of this would be, people who have a very negative or emotional reaction or annoyance reaction to people who, for example, chew with their mouth full, or slamming or impact sounds of doors, or
crinkling of a water bottle.
Yeah, or crinkling of paper. I mean, these sounds are not loud.
No.
They're not considered like hyperacusis loud.
Yeah.
But they exist in our environments, or typing on keyboard is often I hear as well.
Yeah.
And imagine you have to type all day long on the keyboard at work, and you are annoyed by that. Like, how are you going to do that work, right? Or I have another client who is, I wouldn't say even he's severe, but he would tell me that whenever he and his wife has to go to a supermarket, and sometimes they have to open those freezer doors to get things out of the freezer, and hears that loud HVAC sound.
Oh.
He has to actually tell his wife that he has to leave the grocery store and wait for her outside. Now, initially, before the consultation, his wife is 100% sure that this is just an excuse he uses to get out of not going grocery shopping and just sitting in his car, right? But the reality is that over time, she sees the consistency. He's not making this up. No, he is severely bothered.
Yeah.
And these mesophonic patients are severely bothered. And to a more of a higher degree stage, where it develops into something else called phonophobia. And what is that?
So that's sort of like a branch off of misophonia, but this is actually a fear-based reaction to something. And again, it doesn't have to be a loud sound. It can be loud or soft, but the main component is a fearful reaction. Yeah,
perfect. Okay, so hopefully you guys kind of understand. So the questions we asked you is this, right? Ask yourself this. If you have tinnitus and you're watching this, ask yourself, are you annoyed, avoidance, or do you have a sensitivity to all loud sounds? And oftentimes these people will say, yeah, you're right. Like I can't stand theaters. I can't even watch a movie now. I used to be able to, when I was dating, and now if you invite me to a movie, I wouldn't go.
Yeah.
Or halfway through the movie, I have to leave because it's too loud in there. Or when the movie starts, I'm like, wow, like turn it down, please, right? My sister's like that. I don't know if she has misophonia or she's just like that, but she's been like that forever.
Really?
But yeah, I remember, and I don't know if I should tell the story to everybody on the internet, but I'm going to do it anyways, is that I remember the first Star Wars, like the episode 1, when they remake when not the remaking of the 4, 5, and 6, when they did, I think it's the New Hope or something like that, episode 1, and I was going to watch it, and I remember the beginning scene, the that one, right?
Yeah.
Okay, instantly she gets up, and nobody knows what she's doing. She gets up, she runs out the theater, and all of a sudden, the entire movie theater, the sound just dropped. Like it just kind of muted by a few decibels, and everyone's like, "What the hell? Like who turned down the sound?" Like imagine you start a movie and somebody turned down the sound.
Right.
We had to watch the whole movie on a muted state because she complained that it was too loud.
Really?
Yeah. So those people have.
I didn't know you could do
I don't know if she has, but these are the reactions, if you will, of people, and it is extreme. So people who have hyperacusis or misophonia. The people around them, they all know it. So not just ask yourself, but ask the people around you, hey, do I have sounds that I'm, especially have a pet peeve to, kind of thing, that kind of thing.
Yeah.
I guess everybody is, doesn't like the Freddy with the nails on that scratching on the blackboard. I get that. But it's much more than that. So if you have it, you should be easily identifiable.
Yeah.
And so don't underestimate this. Why is this important? And why do we care about asking these questions about, the tolerance to loud sounds and tolerance to soft sounds and an annoyance factor and all that stuff? Why do we care about TST? What is the significance here?
So do you remember when I talked about acoustic shock a little while ago? So that's actually related to DST.
Okay.
That can be the initial cause of DST.
So you're telling me that an acoustic shock can cause a condition reflex, I guess?
Yep, exactly. And it doesn't have to be a series of these traumas.
Okay.
It can be just one single event.
Okay, so a single event can just a shock, right?
A shock, yeah. So for example, we see a lot of motor vehicle accident patients.
Okay.
And in those situations, say if the airbag goes, that can reach anywhere from 140 to 160 decibels. And that single event can then cause an underlying problem of hyperacusis, for example.
And did you know that a gunshot is rated at 140 to 180? So oftentimes we describe it. I mean, because I don't think anybody actually hears the impact sound of the airbags. They just feel it more physically than everything, or the impact of the vehicles hitting each other. But the sound that is associated is oftentimes not being recollected or registered in the brain, but nonetheless, it is being heard.
Yeah.
And imagine firing a gun potentially with the windows up inside a car. That is a shock. But shock doesn't necessarily just come from motor vehicle accidents.
No.
I remember there's lots of cases where a patient says, I remember there's a case about a patient, they were at Stanley Park in Vancouver, right? And in the summertime, those canyons that, that the old canyons, canyons that, like, you look at it, you would think it's dormant, right? They plug the hole, you can just sit on it right on all day long kind of thing.
Yeah.
But those are live canyons, And this patient, when they were just walking by, enjoying, they didn't suspect it, right? So that's what we mean by the shock factor. All of a sudden the cannon went off and it shocked them. And from that day forward, these symptoms or these conditions start to build. It doesn't just come to a stage right away. It's an important thing to know. It progressively gets worse over time. So the association, so what we say for motor vehicle accidents, you just said, is that the initial impact of the sound is loud. So what happens in the brain when we talk about conditioned reflexes is that we start to attach, certain things. So like even very simple, like if you had an accident, a major accident at this particular intersection or this section of road, a lot of people bypass that road. They literally drive by it, or if they have to drive through it, they have a sensation of anxiety that builds up. Or if they had an accident at a traffic light intersection, and every time they go over this traffic light, where they turn left and they got hit badly or whatever, they wait until it's like red light before they turn.
Yeah.
Those are the people that do that. And when you ask them, why do you do that? Well, because remember 5 years ago I had this accident where I was turning left, I jumped at yellow and then boom, I got hit.
Yeah.
So these people these are conditioned reflexes. These are subconscious in our brain that controls our actions and reactions that forces us or guides us to do different things. So not only does our brain look at the physicality of the situation, and also maybe potentially the visual aspect and smell, right?
Yeah.
But hearing or sound is also very much associated. So in a motor vehicle accident, the impact sound, that loud sounds, begin to condition the brain to say, well, all loud sounds must be bad because I want to prevent this trauma from happening again. And now it starts to attach slowly to other loud sounds. And before you know it, all loud sounds become an annoyance, because your brain is your conditioned subconscious brain is naturally trying to prevent you from beginning that trauma again.
Yeah.
And that is the key to why we say, we look for these acoustic trauma, or we look for these answers to these questions, and that's part of what we do in our assessment. Okay, but there's actually one more condition that actually is very, very puzzling, because this one is a tough one for a lot of people in our industry, whether you see a doctor, because this one fluctuates.
Yeah.
And can you tell us a little bit about what is this one called?
So this is called TTS, or something called Tensor Tympani syndrome. And like you said, this is very common and it can be quite difficult to diagnose. And it's really important not to miss out on this specific one. And basically what it is, it's an involuntary condition where the tensor tympani muscle in here, and maybe we can show a slide as well, it contracts a yielding number of behavioral symptoms. So you can get a fullness in the ear, pain in the ear. Some people find that it's almost like a muffled sensation.
And what is really important when we look at this slide here is that muscle that you see, that muscle controls the opening and closing of the eustachian tube. And the eustachian tube is the tube that is inside the middle part of the ear. This is this one right here, okay? And so on the diagram you see that allows the air to come in and out from our lungs to the middle part of the ear. And if so normally in normal functioning of the eustachian tube, it opens and closes as needed to be able to fill the air back into the middle ear, so that our eardrum stays nice and flat. I think people have been in planes before where they have a cold and then they go and then right away when it flies up, you get this
pain.
Like you feel that eustachian to literally get plugged, and they feel the pain in the neck right here, right?
Yeah.
And then into the middle part of the ear. Well, what happens is that you block the tube, and now air naturally escapes from the middle part of the ear, but you're not refilling it back. So now you've created effectively a negative pressure in the middle ear system, and the eardrum begins to suck in like this. And when the eardrum begins to suck in like that, you feel the pain. And that's kind of what people are talking about. So in extreme cases, when the plane starts to drop again and you still haven't unplugged or unclogged the eustachian tube, that eardrum actually just tears, and that bead of blood comes down. So it's not blood coming from your brain or anything like that, but these people are fine. They walk off the plane and stuff like that, right? So getting back to the TTS or the tensor tympani muscle. So the important thing to understand, and this is a crucial understanding here, is that the tensor tympani muscle is not part of the acoustic reflex. So it's not triggered by sound, okay? No. It is controlled by the neurological network, which controls the eustachian tube, okay? So
it's like a conditioned reflex.
Exactly. So it is the reactions in your brain that controls the contractions of this. So when we talk about tensor tympani syndrome, it's activated, interestingly, by the autonomic nervous system. So if we put it all back together again, remember the limbic system, the autonomic nervous system. If the autonomic system is activated, it can potentially, and because of an acoustic shock component, it can potentially build into these hyperacusis, misophonia symptoms, and hopefully not phonophobia, but at the misophonic stage, or even hyperacusis stage, we begin to see potential signs of these TTS.
Yeah.
So let's look at the prevalence and some of the symptoms of this thing. So again, what are the symptoms of TTS that people should look out for, Lacey?
Yeah, so that muffledness or fullness sensation in the ear, pulsation, or almost like a fluttering or a feeling of vibration.
We hear that a lot.
Yeah, fluttering is very common. Pain. Any abnormal acoustic sensations, so almost like a tickling sensation, or like murmurs.
Tinkling. I feel tinkling. Like people feel like, or numbness even in that side of the face. Those are giveaways, right?
Tension headaches, vertigo.
It's like the ring around the head, they just tighten like that. Okay.
Dizziness. And
vertigo, just in case, is when you feel that you're still but the room is spinning, right? That's vertigo, okay? Dizziness is when you are dizzy and the room is not really moving, right?
Not getting your bearings right, like if you're feeling a little bit uneasy or dizzy, and tinnitus.
And the most important one, tinnitus. So tinnitus is a common so when people come to us with tinnitus, we not only have to look at you holistically and look at other causes, but from what we know, we look for your causes. We look for any acoustic shocking, right? Or hyperacusis symptoms or misophonia symptoms, and then if that is the case, this could potentially, and then with the fluctuations of the hearing, muffledness, and it comes and goes. So the funny thing about TTS is that it's not constant. It comes and it goes, and it may get from 0 to 10, like in degree of severity, or it may go never from 0, but it may go from 3 to 7. It may fluctuate in between here, right? So just understand that these symptoms vary quite a bit, and you don't have to check everything off on the list that we just talked about. It is you could have 1, 3, 5, 7, or 1, 3 only, and doesn't mean that we rule out this thing. Now again, we're not saying that if you have these symptoms you must have TTS. So the key thing is to be able to identify the whole cause and everything, right? Some things are easy giveaways, right? And not everybody remembers all of their kind of acoustic shocks and stuff that it may not come to you, right?
No, and that's why we have to go through that questionnaire.
Right. So let's talk about the prevalence of tensor tympani syndrome in hyperacusis patients. So how many percent are we talking about, Lacey?
So it's actually a very high percentage. 94% of DST patients also have these symptoms. So 65% of them have pain, 51% oral blockage, or that full feeling, mild vertigo, 27%, that fluttering sensation, 20%, muffled hearing is 18%, headache, another 18%, and then also that numbness and burning is 8%.
Wow, that is 94%. I mean, that's a lot. So that's why we do pay attention to this. And when treatment of tinnitus completely, in my opinion, completely disregard DST and asking about, tensor Tympani syndrome, like we totally miss the cause.
Yeah.
And we'll talk about that one last bit. So what about prevalence of TTS in just tinnitus patients? So these patients we drilled in, we really worked on looking at DST causes and relationship, and there's none. So they have no issues with loud sounds. They have no issues with, or you have no issues with any sounds that is loud or soft. So it's just tinnitus. How prevalent is TTS then?
A little bit lower, so 37% of tinnitus patients, and then
Still more than 1/3.
Still quite a bit. Yeah. And of those, about 27% experience pain, 22% oral blockage or that fullness, and then 12% for like a physical blockage, numbness and burning 10%, mild vertigo 8%, and then that fluttering sensation around 6%.
Yeah. So I think to sum it up from this DST part of the discussion here is that, it is very important for us to be able to identify correctly what the cause is. Again, if you don't identify the cause and you always just look for symptoms and try to treat symptoms, that is the bandage solution, right? So do not ever think that, that is your first cause. If we can't do anything else, absolutely, TTS will help, okay? But if we can find the DST portion of the diagnosis, by treating DST, and that's any of these conditions, if we're successful in treating, and we are very successful in treating our DST conditions, actually. It's amazing how we can treat hyperacusis. So patients of ours have gone back from not being able to watch a movie to being able to watch a movie, okay? Or I have a patient who was telling me the story about during Chinese New Year. For those of you that have, sometimes you see in Chinatown, they got these line dances, they go like that kind of thing, right? They hold on to the lines set, right? And it's then the drum alongside with that, and it's really loud, right?
Yeah.
So this patient of mine, he was saying that he couldn't go to theaters, he couldn't stand any loud restaurants, even normal restaurants without any of these ceremonial things. And it was Chinese New Year, it just happened, and then he didn't even expect it that they invited the lion dance group to come in. And he literally watched the whole thing. And afterwards, he said to himself, oh wow, I sat through that.
Yeah.
And he was one of those patients that went from 88 to like 16, kind of thing. So it's amazing. It's amazing. And subsequently, by getting rid of, treating the DST, his tinnitus is gotten much, much better. And in his words, almost gone in his words.
Yeah.
So again, cause, symptoms, right? If we find the right cause, we can treat the symptom.
Yeah.
And this is one that is within the program of TRT that we do treat, okay?
Yeah, even though it's called tinnitus retraining therapy.
It should be called tinnitus and DST retraining therapy.
Yeah.
Or treatment, okay? Yeah. Something for us to talk to our professor about. Okay, so let's kind of conclude everything in terms of the protocol for TRT, right? So what are the stages, or what really happens again, so that we just let our viewers know kind of what is the stages, and then we'll talk about kind of how much it is, right?
Yeah. So we'll do a brief overview. So you come in for an introduction with us, get to know a little bit about us. We'll do the initial interview. And again, that part can be over the phone, remotely, in clinic as well.
Telehealth is what we practice now.
Yeah, for the time being. And then we'll go into the audiological evaluation, so the actual testing portion, medical evaluation, and the diagnostics and determination of treatment category. So basically figuring out what kind of protocol we're using for you. Then we're going to also go over the retraining counseling as well. And after that, we'll go into follow-up visits, counseling, and again, audiological evaluation. So basically, each person's going to have a different type of protocol. The treatment will go anywhere from 4 up to 24 months.
What do you mean by different types of protocol? Like, are there different, like, you mentioned something about categories. So is there a different category for each of these tinnitus and Does that relate to the DST as well?
Exactly. Yep. So say if someone comes in with more mild case, if it's just tinnitus, we might set them up with something like a generator to use at bedtime.
Yeah.
Where if it's a more severe case, or if they have underlying issues with, say, misophonia, they may have a different protocol where they use this in conjunction with the sound speakers during the day.
Yeah, and then there's one last thing where, if they have hearing loss, we can also kill 3 birds with one stone, or 2 birds with one stone. So then we can actually help them with the hearing and along with the other stuff, right? Okay.
Yeah.
And if we combine, if you think about it, right? If your hearing loss has some, so don't think about cause and symptoms as 100% or absolute ones and zeros here, right? I mean, when we look at our stress levels, we don't just say, oh, okay, it's because of my back pain that causes my 100% of my stress. It's not true. My back pain probably contributes 20%.
Yep.
And the fact that I'm sitting at home in quarantine and isolate causes another 40% of stress. And then the fact that, I don't have a job anymore or whatever, right? That cause, so it's an additive, it's a bucket. It's a bucket of stress. Okay, I just got to think like that, right? So when we look at tinnitus, it's also a bucket of tinnitus. It's a bucket of the stress. So maybe your hearing loss is contributing 20%. Maybe your DST symptoms are contributing 40%. And maybe your TTS on top of that is causing another 40%. So if we start to remove these components, right, you start to treat these components, then you see these progressive improvements in your tinnitus, right? And hopefully down to a level where you say, hey, I'm treated.
Yeah, we have to take all those into consideration.
And then our mission is done.
Yes.
Okay.
Then we can stand on the hill with our capes.
Yes.
So how about treatment options and pricing?
Yeah. So when we look at pricing, so we break it out into 3 parts here, right? So, and maybe there's a fourth, 3.5. So first thing is what we call the initial TRT assessment. Okay. So hopefully by watching this video, you guys have learned a lot about in much more detail than we can possibly do in the clinic format, right? I mean, when you guys come in, there's also always a time restraint on how much we can tell you. But I hope through this series, the mini series that we just did, we have presented to you guys a comprehensive understanding. I mean, in my opinion, this is as good as it gets. We try to write this in a synopsis and give it to people, but it's nothing like this. So hopefully in this video format, you guys have learned a lot about the education behind it, okay? And so when you come in, we can just go right into the TRT assessment. And that is, remember, the kind of the testing to 20,000 hertz and tinnitus matching and doing the evaluation scales and charting and capturing the instantaneous moment of your situation or prognosis at that moment, including the categorizing of your case so that we can plan out a treatment plan. Okay, so that is $450, and usually we take about 3 hours to do in total. So we break it up into 2 sessions, but now we can do a lot of it by telehealth, right? So the only part that we really need to do perhaps is just the testing part, which we hope we can figure out very soon to do curbside or remotely. But in the clinic we can absolutely do that. Okay, so that is $450 for the tinnitus assessment. If you guys have tinnitus and you guys have and you have one of the options, or you do not want to live with this, the least you can do is diagnose, right? If you feel that you're not as healthy, or you haven't done blood work, or you haven't had an annual visit in years, the least you can do is do your blood work, right? Nobody's asking you to do any treatment, nobody's sending you to do any ultrasounds, nobody's sending you to do any surgeries. All we're doing is just the blood work part, right? So this is the assessment, okay? And that's $450, okay? The second part is once we have determined that we can help you. Now, we may not be, right? Because a lot of times we refer you back out to other things and other disciplines to try to help you. But if we determine that we can indeed help you with TRT treatment, then the next sessions will be the complete payment of the sessions for all of the appointments up to 24 months, okay? And at minimum, we either see each other or talk to each other. A lot of the appointments are protocol settings and reinforcements of protocols and reinforcements as we adjust the sound. We can now adjust even we would call remote support, maybe, right? And Lacey does a lot of that. So what exactly can you do? You can do a lot of things, right?
You can, yeah. So with a lot of the devices that we use for the sound therapy treatment, we're actually able to remotely tune in to our patients. So all we need is on our end, we have our computer with our webcam, and then if you have a smartphone, then we send you a link to download, and we can actually remotely adjust the sound generators wherever you are.
All your settings, actually.
Yeah.
90% plus of your settings, or 95% of your settings on your devices remotely, right? And reinforcing protocol. Sometimes people seem to forget the how loud they should set things and how they progress through time. So depending on whether or not you have just hyperacusis, or misophonia, or you have just tinnitus, or you have TTS, the treatment protocols are compounding sometimes, or sometimes sequentially we have to treat one after another. So that is what we do within the TRT sessions, and that for all those appointments, one-time payment is $2,100. Okay, so at this moment, a lot of times we get asked, so what about the speaker you guys talk about? How much is this thing?
Right. $150.
$150. So this may be all you need if you have a very milder case and of your just tinnitus. Maybe this is all we need. And I know people sometimes ask me, $150 for a speaker is kind of expensive. When you can go to Source, or Best Buy and buy one for $40 or $50. But this one is special. This one is made by a company called Sound Oasis, and Sound Oasis goes out to the environments. And there's 20 different sounds in here, but they record live for 9 hours straight on average, okay? And not every sound is as long, but I mean, most sounds is actually a real sound that they have recorded.
Yeah.
So I remember, they would tell me that they came to Alberta actually to record a sound. I think it's either the waterfall sound or something, but they recorded for 9 hours, and this is like record the live mic, so that the key importance is that the signal does not repeat in our brain. And if there's all the sound generators that I've ever seen online and that you can buy in the stores, they repeat after like 30 seconds, 1 minute, or minute and a half.
Right, and your brain, can detect that loop.
Exactly,
Yeah.
And it's ineffective. So if you're doing that now, you might as well turn on the fan. It's probably better that way. Okay, and lots of people have.
Yep.
It's amazing. Like they come in and they say, "Oh, I sleep with the fan on. I sleep with the TV on." And we ask them, "Well, why do you do that?" And by the way, they can tell you, "Oh, it distracts me." There's in part the same thing. They have learned in themselves to practice sound therapy.
Yep.
But remember, you can practice yoga and you can learn to lift weights yourself. But if you don't have good proper instructions, you're missing the directive counseling portion. And you're not going to see the results that you're supposed to see. So if we're just talking about lifting weights or losing weight, I guess it's okay. I've been doing this weight loss program for the last 20 years, and it's marginally successful, and I just jump up and down like this, right? But if you're living with tinnitus, it's a different thing, right? So okay. So the last question, of course, is that when do we use, when we need to use sound generators, or when we need to use hearing device or combo devices where we're treating hearing loss as well, or all the hearing aids that we have that we sell at our clinic have sound generators built in already. So we can utilize one component or the next. And how much is that, Lacey?
So that will range anywhere from $2,400 up to about $8,000.
For a pair.
For a pair, yeah. And the reason that they fluctuate is, say if someone has a hearing loss, or if they want a more, I call it like a high resolution sound, that's a difference in the cost factor. Yeah. Yeah,
and so we have a discussion about that. Sometimes it is about cost, but other times we would give you a strong recommendation about kind of what we think would be best. Because as you go higher in hearing aids, it's the same thing for people with hearing loss. They ask me this question about what hearing aid level should I buy. I guess if money is not the object, of course buy the best, right? But the thing is, sometimes we do need to utilize the functionality or the resolution within the hearing device. And that's a lot to do with the individual's hearing loss. So everything's on a case-by-case basis, but that is the price. That is the complete price. And remember, it's 83% success rate. So the question is, do you bet on something that is, have no scientific proof whatsoever? So like acupuncture. So for as many people that says it works, there's probably just as many people or more that says it doesn't work, right? Or do you bet on other programs where the efficacy is not even published, or maybe it's less than 50%, right? Then now you're just wasting a lot of time and valuable time, because don't forget, these conditions often gets worse over time. So, I hope that we have given you a case to think about, and hopefully offer you a hand to hold on to if you guys have tinnitus here.